First, I want to introduce Professor Khaled Yassen, the head of Anesthesia Department in National Liver Institute, Menoufia University, Egypt. He has acquired his MD degree from Cairo, Egypt, and fellowship from Royal College of Ireland. At present, he is working as head of Anesthesia Unit Surgery Department, College of Medicine, King Faisal University. No doubt, Professor Khaled has given his best by sharing his expertise and knowledge in every way possible to assist his students and colleagues. I'm one of those blessed ones who have uh, the chance to work with him. His services and endeavors for the progress of anesthesia unit are really well remarkable. I'm sure that all of you here would learn a lot from his valuable input. And without wasting any time, I would like to welcome Professor Khaled Yassen for his presentation. Sir, please.
Okay, thank you very much, Dr. Shahwar, for this nice introduction. I will start straightforward with our work. We will be talking about Alveolar recruitment for hepatic patients during liver transplant. And as Professor Khafir Garcia said, this is something new, and it was not done actually during surgery. So we will present how important it is for us. This lecture has been prepared between me and Dr. Minnatullah Al-Shafei, one of our lecturers in the National Liver Institute. So we start by Bismillah ar-Rahman ar-Rahim. This is my conflict of interest. And this is the building where most of our work in liver transplant is being done in Menoufia University, the National Liver Institute. I come from the Menoufia University, which is situated in the Nile Delta in Egypt. This is our operating rooms, which is important to be well equipped as any liver transplant room to allow for monitoring our patients and developing research to improve patient safety. To start with, defining alveolar recruitment is a ventilator strategy to re-expand alveoli peripherally collapsed. And I was very happy to see the pictures, live pictures that Professor Khafir Garcia showed to us, showing the movement of the alveoli and how important it is. And during our training on workshops with Professor Khafir, we were able to see in experimental animals how alveolar recruitment is very important. In order to maintain this recruitment, you have to use an optimal PEEP, which varies from individual to another. So, I don't know what happened. I'm losing, it's not turning. Oh yeah, here we are. We are dealing with almost 300 million alveoli in the lungs. We have 3 lung zones, which differ from one area to another in their ventilation. And West in physiology actually taught us about 3 lung zones, which depend on the, was playing with me. Let me open it again and go quickly through the slides. Okay. The recruitment of alveoli, how can it happen during surgery? If you are giving low tidal volumes, if you don't have an adequate PEEP pressure, if you are using high oxygen concentrations, you can lead to absorption atelectasis, and if there is disconnection. One of the important studies from hospital registry looking after 69,000 patients in Massachusetts, in Boston, actually recommended that we should look after intraoperative protective ventilation and that we need to decrease. This will help us decrease risk of post-operative respiratory problems and complications. How can we recruit the patients? As Professor Khafir mentioned, we have 2 techniques, a fast recruitment technique and a slow recruitment technique. We adopt the slow recruitment technique using a stepwise increase in airway pressure with PEEP. This is Professor Yahya Khater in Cairo University. He first alerted us all in several of our meetings about the importance of alveolar recruitment. And here he was presenting an important lecture in one of the conferences in Egypt that highlighted and lighted us about the importance of stepwise recruitment of alveoli. How do we do this? We always have a constant ventilator driving pressure. of a maximum 15 centimeters water, and we start by step in 2 to 5 centimeters water increase in PEEP. We do this guided by dynamic compliance until we reach to the maximum of compliance, and then we start going down gradually until we reach to the optimal PEEP, in which the dynamic compliance will decrease abruptly afterwards. This has now been developed, and there is a software for it available in several anesthesia machines. This is one of our anesthesia machines in Menoufia University, where we can apply the numbers that we want, and we can repeat the recruitment during long surgeries as liver transplant. Optimal PEEP is very important. As we said, we usually use, most of us, 5 centimeter water PEEP, physiological PEEP, but that is not enough. An optimal PEEP recruitment could be 9, could be 8 centimeters, could be 10, could be more. And it differs from an individual to another. And it can affect hemodynamic changes, so you have to monitor your hemodynamics. Why do we need to recruit alveoli during major liver surgery? We need to do this because it will help us improve post-operative pulmonary complications, because we give anesthesia for long times that reduce the functional residual capacity, and most important, that there is extensive surgical retractors applied to our patients, and most of the patients can come in with ascites, particularly hepatic patients. This is an example of how extensive retractor can be. This is retractors that can retract the lower part of the lungs and lead to collapse. If we don't use recruitment, most probably these peripheral parts of alveoli are collapsed during surgery, and this will increase the incidence of post-operative complications. In liver transplant, few recruitment researchers and few people approached that point. We will go through this research. This is a research in 2006 from China that proved that recruitment can be done and it is safe to practice, but they only practiced it in ICU when they suffered from acute lung injury to enhance the weaning of their liver transplant patients. Another study in 2007, that was on an experimental rabbits, and it showed that from their point of view, that liver dysfunction is a concern during lung recruitment with pressure controlled ventilation. But in 2011, another study working in pigs did show that hepatic effects of lung recruitment do not happen. Pigs do not, recruitment do not cause hepatic dysfunctions. Beneficial respiratory effects of recruitment of paracentesis itself in cirrhotic patients was evident in such a study in 2011. With paracentesis, we were able to remove massive amounts of ascites. And this is our daily practice in caring for hepatic patients. For example, intra-abdominal pressure, when it is reduced from 24 to 12 millimeter mercury, it led to significant improvement in oxygenation and the Peep ratio, as you see in this study published in 2011. Early respiratory complications is a concern, and this is an important study published in 2013, showing that post-operative pulmonary complications following liver transplant is not infectious only, it can be non-infectious, like pleural effusion, like atelectasis, like pulmonary edema, like then developing into pneumonia. A systematic review in 2015 encouraged us to start recruitment maneuvers following the induction of anesthesia in general anesthesia and during maintenance, and whenever we find that our oxygen saturation is going down. Monitoring lung recruitment is essential, like Professor Javier Garcia mentioned in his study. You cannot do recruitment without monitoring it. But how can you recruit patients and do recruitment during surgery under anesthesia? You have to have different options. You have a multifaceted approach. In our next study, we choose compliance for that. We have also other studies about lung ultrasound and electrical impedance tomography. That is expensive and not practical during our intra-operative operating room work. So we rely on compliance. Thank you, Professor Javier Garcia, for visiting us in Cairo and for engaging with us in research. This is a part of your lecture in Cairo University in Qasr Al Aini, where we became more aware of the importance of recruitment. We started with Professor Javier an important joint research for one of our MD theses in Menoufia for Dr. Minatullah Ali Al-Shafei. What we were looking for is studying respiratory and hemodynamic effects of alveolar recruitment during and after liver transplant. Because most of our patients, as our policy in Menoufia, we ventilate them for at least maybe 6 to 12 hours post-operative until we make sure that the graft functions are working. We did this work in living-related live donor liver transplants and not in the cadaveric ones. So the study was done. This is a nice picture from the European Society in Austria, where Minatullah on the left side and Dr. Nagla, our third speaker today, went to Austria. They presented it. It was well accepted in the journal and published as an abstract in the proceedings of the conference in the European Journal of Anesthesiology. What was the idea of this research? The research was we are going to do prophylactic recruitment. This trial is one of the few in the world to address the effects of prophylactic lung recruitment during liver transplant. The results demonstrated that most of our liver transplant patients were hemodynamically stable and could tolerate the recruitment, even during phases of anhepatic, even during reperfusion phases. But in our flow chart, we were able to locate 1 or 2 or 3 individual patients where we had to de-recruit, then re-recruit after the episode of hypotension. So it is important to keep in mind, if you do recruitment, you have to monitor your hemodynamics, as well as monitoring, of course, the dynamic compliance of the lung. Looking at your hemodynamics is very important. Our primary aim was to look at the effect of this recruitment on your oxygenation and dynamic pulmonary compliance, and look at what we all were afraid of, which is the liver graft blood flow. We monitored it intraoperatively, and we monitored it post-operatively. We looked at the systemic hemodynamics, and we looked at the incidence of post-operative pulmonary complications, which was reduced significantly in the group with recruitment. We use transesophageal Doppler in our institute to monitor hemodynamics, which is very good for us. We use it for cardiac output monitoring, systemic vascular resistance monitoring, and guiding fluid management. But you can also use electrocardiometry, which we are working now on a study evaluating the importance of electrocardiometry as a non-invasive and a cheap way of monitoring your cardiac output. We also monitor anesthesia depths, which you have when you are recruiting patients. Don't give them excess anesthesia, particularly during liver transplant, when we are in the anhepatic phase, where the amount of anesthetic requirement is reduced significantly. So because if you give excess anesthesia, this will affect your hemodynamics. So we use the patient to control the analgesia, patient state index of Massim. This is our type of patients, cirrhotic, so they cannot tolerate excess anesthetics. And this was one of our studies demonstrating that patients more anesthesia monitored, the anesthesia depths monitored, led to a reduction in the sevoflurane consumption. They are not healthy liver patients. They need an adequate amount of anesthesia and not more than that. And it varies from an individual to another. This is the way we did in our study. We adopted the stepwise recruitment maneuver. And as we said, we will have a driving pressure of 15 centimeter water, and we will start increasing the Peep value incrementally until we reach to 35, 40, and then we go down to detect the optimal Peep. So alveolar recruitment was performed after intubation, after applying surgical retractors. As you see, these are the surgical retractors. They are very good, very strong surgical retractors that can lead to atelectasis at the lower end of the lung. They need it, and the surgeons need it to help them ventilate the patient. This picture is so important, where it shows to us for the first time that the lung, this is when the liver was removed from the body. There is no liver now. So we can see the diaphragm. And for the surprise of us and the surgeons, we could see clearly the lower part of the lung bulging out. And previously, when we were not recruiting our patients, this part of the lung was not bulging out. Now we can aerate this part of the lung very clearly. I'll show you a small video about it. This is the lower part of the lung, and it's bulging. That was the first thing that the surgeons noticed. And this is an aerated lower part of the lung. That was dramatically very important because it led to improvement. This is real pictures from our monitors. We can show you the first Peep was 5, show you from the control group. The compliance was 30. Look at the oxygenation in the blood, 145 millimeter mercury. In the next slide, when we started, I beg your pardon. When we started recruitment, our Peep was 10, compliance increased to 55, and oxygenation improved dramatically. These are results from our study showing that all through the phases, the one in orange, your oxygenation were much better from the control group. This is a randomized control study. And here the ratio was all the way improved in recruited patients. Dynamic compliance was much better in all of the patients. All of them were statistically significant. We monitored the hemodynamics post-operatively as well. Cardiac output during surgery was not affected in both groups. This means that recruitment, if done well and individualized, it will not affect our hemodynamics. The central venous pressure, for our surprise, was affected and was increased in the recruitment group. But as we said, in the transesophageal Doppler, we use an alternative for a CVP, which is called corrected flow time. It was not affected by recruitment, and that opened the window for another type of research where the recruitment high pressures do affect CVP, which you can't use for guiding your fluids if it is affected. But here, the corrected flow time and stroke volume variations were not affected. The lessons we learned from this trial, first lesson is that individual variations do exist, and variations between surgery, different phases of liver transplant must be respected. Optimal Peep must be monitored continuously and maintained. The second lesson was always assess the fluid status prior to the cessation of lung recruitment. Sometimes when we get episodes of hypotension during surgery, our colleagues not familiar with recruitment will ask us to re-recruit patients. But actually, we need first to check if the patient is fluid normovolemic or not. Because when we give fluids, sometimes we don't need to de-recruit and lose all the benefits. Sometimes in hypotension, we can use incremental small doses of ephedrine. But if it does not respond, then we will de-recruit. Conclusions, individual recruitment is important. Lung dynamic compliance was improved, as well as oxygenation. There is a significant reduction in post-operative pulmonary complications. Systemic hemodynamics were not affected. Graft, hepatic, hemodynamics, like portal vein and hepatic artery, were also not affected. During hypotension episodes, recruitment needs to be monitored and adjusted. Transesophageal Doppler corrected flow time is very suitable during recruitment and need to be studied further. Because as Professor Khafir said, we were very lucky to have it at the beginning of this year accepted in the Experimental and Clinical Transplantation Journal, and it will be very soon available online. The next lecture will be presented by Dr. Nagla. As I said, it's a very important lecture. Repeating the same work in liver resection surgery was presented in the American Society and was done by Dr. Amani Mamdouh, who had a prize for that presentation. Further readings, you can refer to my just recent book about anesthesia, my contribution in King's College book about live donor hepatectomy, and most of the developments and protocols of our institute is available there. Future research in our liver institute, we are studying now oxygen reserve index as a guide for alveolar recruitment, and it's part of an MD research. It is a Massimo ORI software. Thank you.
So the questions from Dr. Khaled. The first question is how to do lung recruitment during assisted ventilation in preterm infants.
Oh, in infants. We haven't done that. Maybe I'll leave that to Professor Khafir to answer it, because he's the specialist in pediatric. Are you with us, Professor Khafir?
I think that question had been asked before.
Yes, I'm here.
Okay.
Yeah. Yeah, there was a question. Yeah, about, can you repeat the question, Dr. Shah?
How to do lung recruitment during assisted ventilation in preterm infants?
Okay, if the patient, it doesn't matter if it's children or adults, if the patient is spontaneously breathing, then you cannot recruit in the way we have explained. In spontaneously breathing, it's totally different. The only thing you can do is to increase CPAP or Peep, and then hope that the spontaneously breathing, the driving pressure created by the muscle of the patient can create that, but it's difficult. In my opinion, if you have a patient who need recruit maneuvers, it's not needed to block with muscle relaxant, but it should be deep sedated. And then you can recruit it, set the PEEP, and then put the patient into spontaneously breathing again. So it cannot be done, or the story is like the patient can cough. And if the patient cough in the overdistension area, it's dangerous.
Okay, the next question is, thank you, Dr. Ghafir. The next question is how to assess lung recruitment by ultrasound. Dr. Khaled.
Yeah, this is a very interesting. During the last conference, when I was presenting the work in the American Society, there was a colleague from Canada, and he was trying to develop his way and technique in using ultrasound for it. I'm actually waiting to look into this study. I don't have enough experience into it, but people are working on using ultrasound to guide recruitment in a lung. Do you have, Professor Khafir, something to add to this?
Okay,
ultrasound
I think ultrasounds is quite really. I highly recommend everybody go for that because the learning curve is quite easy. The only thing you have to do is to put the prone in the back part of the left side. Why in the left side? Because the heart is in the left side. So you put the prone in the area who is more prone to have collapse. So you put the prone whenever you identify that atelectasis, you can, other person have to recruit the lungs for you, and you perfectly see how the images is very simple to see how you change from atelectasis to a full open lung. And then when you are reducing the pressure, exactly the same, we do it in the exactly the same way that we present with a constant driving pressure. When you are going down in a point, you can see perfectly how the lungs recollapse again. This is the collapse point. I will reopen it and then set the PEEP in the step before. So even I can tell you, it's very, very nice. Usually in the side of the OR, it's not possible. This is the PT, but in intensive care, that sometimes you have patients very difficult to set the PEEP, is very useful. And for example, if you have the patient breathing spontaneously, it's a very important tool. Why? Because the only thing you can do is to increase the CPAP. For example, the patient is spontaneously breathing, in pressure support. You increase the CPAP to 10, then you can tell the patient, please breathe deeply with like a sign, like a suspire. If you put the prompt, you can see how the lungs is reopening. So then the only thing you have to do is to reduce PEEP until you can see that during expiration, the lungs don't go for collapse. I highly recommend you go for lung ultrasound for recruit maneuvers because it's quite easy to fix the images from collapse to open lung.
Okay.
Thank you, doctor. The next question is it easy to determine optimum PEEP by ultrasound?
Yes, Professor Khafir, yeah?
Yeah, it's what we said. Yes, the answer, yes, it's not perfectly precise because the story is like not all the areas of the lungs need exactly the same PEEP. So it's what I said just before. You put the prone in the area who are more prone to collapse. That is the back part of the lungs in the left side. So the only thing you have to do is reduction the level of PEEP until the moment that atelectasis reappears. So this is the collapse point that what we show in the slide coincides with a reduction in dynamic compliance. So the only thing you have to do is to reopen it again and set the PEEP in a point who you can see with the ultrasound that the lungs remains open.
Yeah, I can see one of the questions, Dr. Shahwar, about do recruitment increase bleeding in liver transplant? Well, from our practical work, we have to keep this, of course, in mind when we are doing recruitment and notice our hemodynamics, as we said, we need to monitor it. But from our data, from this randomized control study, we could not find any difference, neither in blood loss nor in blood transfusion. But in episodes, of course, for patient safety, we have episodes of hypotension, particularly in reperfusion or in anahepatic phase. This should always be taken in consideration and revised. And we did report in our study that at several occasions we did recruit, de-recruit and cancel our recruitment. And then after episode is over,